Welcome to the Sleep is a Skill podcast. My name is Molly McLaughlin, and I own a company that optimizes sleep through technology, accountability, and behavioral change. Each week, I'll be interviewing world-class experts ranging from doctors, innovators, and thought leaders to give actionable tips and strategies that you can implement to become a more skillful sleeper. Let's jump into your dose of practical sleep training. Welcome to the Sleep is a Skill podcast. This episode is very near and dear to my heart for a personal reason. My fiance's dad was recently diagnosed with ALS, which has sent the whole family really down the rabbit hole on understanding this disease more. And naturally, I had a curiosity around sleep and its role with ALS. So that is the real focus of today's episode. And my hope is that this can become a resource for people, whether a caretaker for someone with ALS or if you have ALS yourself, because sleep, as we'll find out on this podcast, plays a tremendous role in this disease. And then also we get into conversations, even just speculation around could poor sleep play any sort of role in the lead up to diagnosis. Now, of course, we don't have any studies backing that as of right now, but we do have an interesting conversation that takes place just looking at the role of sleep and ALS in totality, and then going deeper, getting into the weeds a bit more on the practical side of this, because of course, as the disease progresses in various ways for many different individuals, sleep can be one of the things that can be impacted. So our aim is to make sure that you have some specifics to walk away with in practical applications. If we left anything out or you have any other questions, please don't hesitate to reach out to myself and, Dr. Richard Bedlack, and then also his colleague, Dr. Wissam Mansour. They're both making themselves available. They've been just tremendous in really aiming to make a difference in this area. So don't hesitate to reach out if you do have any further questions. And without further ado, I'm going to read a little bit more about each one of our guests so that you have a little bit of background going into this podcast. Now, Dr. Richard Bedlack grew up in a small town in central Connecticut. He went to college at William and Mary in Virginia, then back to Connecticut for an MD and PhD in neuroscience at UConn. Finally, he came to Duke, where he completed his medicine internship, neurology residency, neuromuscular fellowship, and master's in clinical research science. He is currently a professor of neurology at Duke and a director of the Duke ALS Clinic. He has won awards for teaching and patient care, including Best Neurology Teacher at Duke, Healthcare Hero, Strength, Hope, and Caring Award, America's Best Doctor, and American Academy of Neurology Patient Advocate of the Year, and ALS Patient Advocate of the Year. He has received ALS research grants, participated in ALS clinical trials, published more than 100 ALS articles, and he is the leader of the International ALS Untangled program, which utilizes social networking to investigate alternative and off-label treatment options for patients with ALS, and leader of the ALS Reversals program, which attempts to understand why some people with ALS recover from it and to make this happen more often. He lives in Durham, North Carolina with his wife, Shelley, and 2 mischievous cats. And then he also brings on the podcast his colleague at Duke, Dr. Wissam Mansour, who was born in Beirut and obtained his medical degree from the Lebanese University. He completed internal medicine residency and pulmonary critical care fellowship training at Northwell Health in Staten Island, New York, followed by sleep medicine fellowship training at Yale University in New Haven, Connecticut. Dr. Mansour currently serves as an assistant professor of medicine, Division of Pulmonary, Allergy, and Critical Care Medicine at Duke University. His clinical and research interests are focused on sleep-related breathing disorders and neuromuscular lung disease. He is particularly interested in advancing our understanding of the pathophysiological mechanisms leading to sleep-disordered breathing and allowing for a more targeted treatment approach. Now, without further ado, let's jump into the podcast. All right, you all. I'm so excited to announce our new sponsor, Soul CBD. When I was at my lowest point dealing with my insomnia, CBD was one of the key compounds that I leaned into to combat my crippling anxiety, calm my nervous system, and support my journey to entrain my circadian rhythm. But of all the brands out there, where can you go that you can have a strong trust in their quality? Well, Soul CBD is completely THC free, organically farmed, gluten free, and third party tested for toxins. Now, one of the things that is great about Soul is that they aim to help create rituals around your CBD use, and sleep and rituals are best friends. For instance, I love that Soul CBD supports a nighttime bath routine with their CBD bath bombs, which help to combat stress, soothe aching muscles with a mix of CBD essential oils and dead sea salts. Another ritual that we aim to cultivate in the realm of sleep optimization is circadian rhythm intermittent fasting, which is really all about eating your meals between sunrise and sunset. And Soul CBD has very popular gummies that can serve as a nighttime dessert or treat to look forward to without caving to ice cream. Nice alternative. My go-tos personally are their oils, capsules, topicals, and even CBD bath bombs. It's helpful for anyone who struggles with anxiety, pain, or sleep. Now, particularly when I'm traveling, I like to lean into as many things as possible to help with inflammation, and CBD does just that. Now, here's a really cool part. You get 15% off automatically and free shipping when you go to mysoul.com/sleep is a skill. I'm going to say that again. You get 15% off automatically. All you have to do is go to this link, which will be in the show notes, mysoulcbd.com/sleep is a skill. All right, let's get on to the show. And welcome to the Sleep is a Skill podcast. I have been so excited for this conversation today. And the reason for this actually is a kind of personal background. My fiance, his dad was recently diagnosed with ALS, which has really sent a lot of emotions and kind of a roller coaster of what next, to how to approach this. And with that, really have gone down the rabbit hole on the topic of ALS. And Duke University has really come up big for me and many people in the ALS community, it seems, for ways to help and approach ALS with real hope versus it's, this sentence of, or what it has to look like, that maybe we could start to rewrite what it could look like. So with that context, I'm really grateful for my guests here today. And I want to just turn the spotlight on to both of you and to be able to share what got you into this space and how this can relate to this topic of sleep, which was what we're going to focus on today, ALS and sleep.
Yeah, thanks so much, Molly. I saw my first person with ALS back in the late 90s when I was still a resident at Duke. And I remember thinking, wow, this is the most amazing and most terrible disease I've ever run across. And, when you're a resident, you learn from an attending. And I remember the attending coming in and saying, this is what it's called, but we really don't know why it happens. And there's nothing we can do about it. You just have to go home and get your affairs in order. And then they just walked out. And I just remember thinking, wow, I feel like I've been punched in the stomach. And if I feel like this, I can only imagine what the patient and family feel like. And drove home that day and thought, there's got to be a better way. And I decided to stay at Duke and try to change the culture here. And so after I graduated, I drove around the country and I saw what other thought leaders were doing. And that led me to this idea, this multidisciplinary approach. And I put together a team. I think we have one of the largest, most comprehensive teams now. Each member of my ALS care team focuses on one specific part of the body, and they have measurements that they make. And if they see that ALS is trying to take something away from that part of the body, then they're trained to offer the patient options. And now people, when they come here, they spend most of the day with us every few months. And each time they leave with a long list of things they can do about the disease to make their lives better and hopefully to make their lives longer. And we've been able to incorporate a lot of research into the clinic, including some very unusual research on alternative and off-label treatments that I think gives people a lot more hope.
Absolutely. Fantastic. And Wissam?
So for me, I have a training in pulmonary and critical care. And my interest in sleep grew during my pulmonary training. Honestly, sleep clinic was a good break from the intensity of the critical care field. And with time, I became more knowledgeable and I had better understanding of how difficult it is for the lungs to function during sleep. So even though everything really rests, the whole body rests, the lungs really don't. And sleep is really a challenge for the lungs. And that's something a lot of individuals are unaware of. The lungs may be in their most vulnerable state during sleep. And so I became more interested in the field. The field is young. There's a lot of potential for research and growth. And my interest led me to doing a fellowship with it. As for the ALS part, Dr. Bedlack was the person who got me into ALS. When I was coming to Duke, we met, we spoke for some time. He convinced me there is a big need. And I felt that I can really make a difference in that clinic. And when I went there, I visited the site. The team was absolutely fabulous. And they always know how to make a difference in the lives of these patients. And that's what led me to join them.
Well, I would also like to underscore that sense of passion and, hope that's come out. Bedlack, you've just really done some tremendous work there. I mean, even just from a personal story, we'd heard this diagnosis back in November and, the entire family crying and just what does this mean? And trying to wrap our heads around this. And it was one of the videos with you speaking and looking at reversals and really taking seriously and listening to patients in such a way with so many years behind you in this field. It really, really made the difference and helped us kind of get back on a track of hope. And I really want to underscore that. So really quite thankful and completely agree with Wissam. And sounds like you're doing amazing work over there at Duke. So without further ado, yeah, absolutely. Absolutely. And want to jump in. So when we talk about ALS and sleep, that's a big topic. And so kind of thinking of it in two parts. And granted, there's so many unknowns in the realm of sleep, at least this is my understanding, and you can educate, but my curiosity is two-part around, could sleep be any sort of contributing factor? And of course, we don't, this is all speculative and with some of the studies coming out, but since we see neurodegenerative issues linked now more widely with certain studies around Alzheimer's, Parkinson's, dementia. Could there be even a topic, or is this a thought process for people that the ALS could be in that similar group? And then second fold around certainly its role in the progression of ALS. So I know it's a big question, but want to just to get it out there, that two-part kind of question.
Yeah, so it's a fascinating question. And let me say at the start that, when you approached me about this podcast, I thought I knew about sleep and ALS. I thought it was mainly sleep-related breathing disorders. And that's why I asked Wissam to join me, because I think he's really an expert in those. But it turns out that's just the tip of the iceberg. And, the specific questions that you sent over to me were kind of an aha moment. I've spent the last week or so just scouring literature, and it's quite fascinating. I must say, I'm not really convinced right now that a sleep disorder could lead to ALS.
Sure.
But I think that there's definitely an association. I think that I did not appreciate how common different sleep problems were in ALS. Most people, it turns out, with ALS have sleep problems. And there's a whole bunch of different categories. We talked about sleep-related breathing disorders, which I know we're going to get into a lot more. Sure. But insomnia, fragmentation of sleep, movement disorders like restless leg and periodic limb movements, and even REM behavior disorders all seem to be much more common in people with ALS. And, they actually seem to have a tremendous impact on the quality of life and, interestingly, even the length of life. It appears that some studies show that people with ALS who have sleep pathology don't live as long. So these are exactly the kind of things that I need to figure out how to target, how to screen for, and how to manage better in my clinic. Again, going all the way back to why I did this in the first place. I want to find things that affect the quality of life and the length of life for patients, screen for those things, and offer options. But one thing that's interesting is why these sleep problems happen. So there's sort of the obvious reasons. Sleep-related breathing disorders, we know there's hypoventilation because of diaphragm weakness and chest wall weakness, but there's a whole bunch of other interesting questions that I sort of got led down the rabbit hole on in my reading. And one, you sent a couple of articles over suggesting that there might be a common pathology, that maybe some of the things that cause ALS are also causing sleep disorders. Like you sent over somebody's thesis. I have no idea how you found that, but it was fascinating, suggesting that TDP-43, a protein that we know is involved in the biology of ALS, that mutations in that protein in animals not only can cause ALS-like disease, but can also affect the sleep-wake cycle. And so it just makes me wonder if there is a common cause. And I also found a paper, another common cause of genetic ALS, which is something called C9orf72. It also creates changes in cells, of course, in motor neurons, which are the cells involved in ALS. But it turns out someone actually did a study where they looked for those same sort of changes in other parts of the brain. And they were found in great quantity in the parts of the brain that are involved in sleep, like the hypothalamus, for example. That was just blew my mind. I'd never seen that before. So, yeah, I mean, I think it's quite possible that there's a lot more problems with sleep than I recognized. And the reason for it is probably multifactorial.
That makes me very, very happy to hear. Just certainly, granted, I know I'm biased to be someone that's created an entire company around sleep optimization. I truly believe it can just be such the foundation to lay for a healthy life in general. But certainly with these pathologies, to hear that sort of commonality around the possible importance of sleep as it relates to ALS, certainly for the hope of aiding in the slowing of the progression of ALS, I should say, that's really, really profound. So, and I just appreciate your willingness to kind of go down the rabbit hole on these topics, because as we're talking about this is where one of the things we're referencing is a pretty recent study out of Israel looking at this potential, and I'm sure you can explain it better, but this buildup of protein, that TDP-43, and it certainly just makes me wonder about one of the foundational elements of sleep throughout deep sleep being that clearing out of amyloid beta as it relates to other neurodegenerative issues. So just so curious if there's any commonality there. Of course, these are very much just questions, but I so thank you for going down that path.
Yeah, it was fascinating. Like I said, I don't even know how you found somebody's thesis that they wrote, but it was a fascinating paper. I couldn't find that thesis had ever been published anywhere else, but this idea that you could actually induce not only an ALS phenotype in an animal model by manipulating the TDP-43 gene, but by manipulating the exact same gene, you can produce a disorder of the sleep-wake cycle. That's amazing.
Well, okay. So, and I loved what you mentioned too, of if this could have some benefit, and certainly we see that there are some future studies, it looks like in the works, where people are looking to explore more around sleep and ALS specifically, and looking to have some larger scale studies down the pike. But in the meantime, curious as far as screening for ALS, its possible role in kind of the ongoing work that we do with ALS clinics. Do you see that as, because I hear you too, there's so much that's thrown at ALS patients and their caregivers. How does that all work? Is that something that could start to go into the fold?
Yeah. So let me start by saying the reason I picked Wissam is, he's young and very interested and passionate about helping people, as you could probably tell already.
Yes.
But he's really sort of my expert on screening for sleep-related breathing disorders and managing those. So I'll let him talk about how he screens and diagnoses and manages those folks. And then I'll talk about some of the other ideas, some of the things I've been doing and that I want to do now after all this reading I've done in the past week.
Yes. Amazing. Awesome. Yeah. Wissam, would love to hear your thoughts.
So understanding that ALS patients have the common sleep problems that anyone can have. So an ALS patient can have the typical insomnia, they can have the sleep apnea, they can have anything that any patient coming into the sleep clinic may have. But on top of that, they have ALS-related sleep disorders. And the elephant in the room has been for several years now, the sleep-related breathing disorder, because of the idea that disturbances in the oxygen and carbon dioxide are going to have a lot of implications on patients' life. This has been the focus of managing ALS patients in most clinics. The way we do it is we try to screen patients through simple questionnaires regarding their shortness of breath, daytime symptoms, sleep quality, daytime naps, nighttime awakenings, morning headaches, waking up with shortness of breath, waking up with gasping awakenings, having shortness of breath when they lie flat. And all of these questions can help us or can lead us to a suspicion that these patients may be having a sleep-related breathing disorder. Now, none of these, unfortunately, is diagnostic. And a big percentage of patients start to develop sleep-related hypoventilation without even realizing it. They might not have any symptoms. And if I can just have a minute, Molly, because I think this is important for ALS patients as well to realize, is that this retention of carbon dioxide during sleep may happen without any overt symptom. Meaning what happens during sleep is that, one, the position of sleep puts their diaphragm into a disadvantage, meaning now the diaphragm is working without the help of gravity. So that by itself leads to hypoventilation. So we start breathing less. Add to that the muscles that get kind of more relaxed when we sleep. So now we're breathing even less. And then when we go into REM sleep, we have a group of breathing accessory muscles that I call them helpers for breathing. These muscles get almost completely paralyzed during REM sleep. And that's a phenomena to protect us from dream enactment. However, in patients who don't have ALS, what happens is the diaphragm starts working overshift to cover for these muscles that got paralyzed because it's not involved in this paralysis, and starts taking care of bringing in enough air and getting rid of it. In ALS patients, the diaphragm may not be able to do that. And so what happens with time is the CO2 starts creeping up during REM sleep. That results in an awakening, a sleep stage shift, so fragmentation of sleep. Patients may not be aware of it because REM sleep is only maybe 10 to 20% of sleep in certain individuals. But with time, the sensors in the brain that are supposed to pick up this change in CO2, that this is something abnormal and we need to act on it, they start acclimating to it. And they start thinking that maybe this is something okay or normal. And so that CO2 retention with the addition of progressive muscle weakness starts occurring even during non-REM sleep. And eventually it starts also occurring during the day without the brain sensing the need to make a difference. So because of this kind of progression, we try to find it as early as possible to try to cut that cycle from happening, to prevent the brain from getting used, these sensors that getting used to this abnormally high CO2 level. That may cause a whole bunch of other problems for our ALS patients.
So ultimately what kills them, right, Wissam? I mean,
that's true.
That's ultimately the cause of death for most of our patients is hypercarbic respiratory failure. The CO2 levels get so high that they can't stay awake. They go into a fatal arrhythmia and they pass, which is usually a comfortable end. But of course, we'd like to try to stretch that out as far as we can.
That's 100% true. So what I just want the patients and their family to know is that sometimes symptoms can be misleading. And that's why in the ALS clinic, every time we do breathing tests, to try to find any subtle finding or any change or signs of muscle weakness that will predict sleep-related hypoventilation. And that will be the point where we will start suggesting treatments, whether doing a sleep study to evaluate if there is really sleep-related hypoventilation or even starting therapy, regardless of the sleep study. Because in the end, we all know that ALS is progressive and you want to try to give them the best chance possible. And there's a lot of data coming out of Europe that very early initiation of non-invasive ventilation has positive prognostic implications, quality of life, and survival. So it's very important to embed these questions and focus on them to try to pick up any sleep-related breathing disorder. I know Dr. Bedlack also went through other sleep-related issues ALS patients may have. We can talk about it more if you'd like.
One of the things I love about Wissam, one of the reasons he fits in so well with our team is that he's so proactive. You know, at Duke, we try to pick up on things really early, and we try to get people the options that they want maybe a little sooner than they're absolutely necessary. So Wissam, I think we're on the same page about if you have any suspicion that somebody may have one of these sleep-related breathing disorders, or we see that the pulmonary function tests, which we do at every visit, are starting to deteriorate. We see a decline, say, in the forced vital capacity down below 60. You know, we're very proactive about explaining and offering and getting, if people want it, non-invasive ventilation. And, that I think that's part of why folks do so well here, is that we are much more proactive about everything, but especially that.
And this is just my being relatively new to this topic of ALS and how this all progresses. Is this something where this is a kind of top-down protocol that you bring about to kind of ALS clinics and throughout ALS Association across state in the United States? So even if someone's in like rural areas or what have you, that they would be having that level of kind of access, or that different clinics are kind of enacting some of these proactive measures, or is it more situational and geographical?
I would say that most ALS clinics around the world, where they actually have a team and somebody who's passionate about the disease who's leading the team, most of them understand the importance of sleep-related breathing disorders, of hypercarbic respiratory failure. Most of them understand the importance of non-invasive ventilation. What differs is when this is discussed for the first time, when it started. I would say, Wissam, you can back me up on this or refute it, but I would say that in general, we probably started a little earlier than many other places. There are places I know that they want a sleep study before they'll start this, or they actually want an abnormal blood gas measurement before we start this. And I feel like, we started at the first symptoms of either dyspnea or orthopnea, or the first symptoms that suggest that somebody may not be getting a good night's sleep, or when the measurements are, getting under 60%. Some clinics use 50%. So I think we're a little bit more proactive maybe than other places.
Yeah, I totally agree. We even try to see if the patient is having a drop in their vital capacity when they lie flat, because that's how you sleep. Right. So testing it when you're upright might not really give you the complete picture. Even if we see a deterioration in the patient's FVC, even if it was in the 100% on the initial visit, and now they're coming in with 80 or 70, which might be normal on paper, but that's not necessarily something that we can disregard. I would start at that point. I think we have enough data that supports that very early initiation of non-invasive ventilation in ALS, more than any other neuromuscular disorder, is beneficial.
The way I think about it, Molly, is, there isn't a light that goes off over someone's head when it's the right time to start any intervention.
Right.
And if I'm going to err on the side of starting something sooner rather than later, I would much rather start it sooner. And this is everything. I mean, this is, non-invasive ventilation, but I mean, it's also things like a walker or a brace or a wheelchair or an exercise program or a nutritional intervention. It's everything in our clinic. At the very first inkling that there might start to be a problem there, we start to have these conversations and we try to start getting the equipment out, getting the therapy out to the patient who needs it sooner rather than later.
Oh, amazing. And then also just kind of demystifying kind of some steps that people take on their road with ALS. We had posted in a couple of the ALS Facebook groups around the fact that we're doing this podcast. And a couple of people mentioned about different types of masks, and are there kind of understanding specific ones that might make more sense for ALS patients, whether the Trilogy, the BiPAP, what have you. Just wondering if you could quickly kind of demystify some of those and at what point those come into play.
Sure. So when I use the term non-invasive ventilation, it's an umbrella for multiple devices. So Trilogy is a brand name. Astral is another brand name. These are the most commonly used out there. These are ventilators, meaning we are able to control a lot of settings. They are more comfortable for patients. And we can do what we call remote monitoring, and we can do adjustments based on the data that come back from the machine. So in addition to being set up with the device, patients have to understand that follow-up is very important, and optimizing these settings to the target is very important, because as ALS is progressing, so their needs are going to change. Even though these devices are very smart and they know how to adapt, we also need to give them these ranges. So Trilogy and Astra are probably the most commonly used home ventilators for ALS patients. Now, can we use a BiPAP? Yes. However, a BiPAP has less flexibility. We cannot use CPAP in ALS. And I see a few patients who come in with a CPAP machine that they use. CPAP will not help with hypoventilation. It might help early on if they have obstructive sleep apnea, but that's not the major problem as ALS progresses. It's more the hypoventilation. So you need a form of ventilation, whether it's BiPAP or preferably a ventilator like a Trilogy or an Astra. Now, these devices are linked to certain masks. We have tons of masks out there. Up to now, there is no significant difference on the interface that they use, meaning if a patient feels more comfortable with a nasal mask, I'm fine with it. If they feel more comfortable with a full face mask, I'm fine with it. That being said, there are small studies that have shown that an oronasal mask may cause pressure on the chin, pushing it backwards, and that may worsen obstructive sleep apnea. So they might need higher pressures to keep that airway open. But since the Trilogy and the Astral devices are smart in a way that they adjust pressures in the face of an obstruction, I'm comfortable using them. I have not changed my practice in terms of mask selection just based on these findings. So if they feel more comfortable with a full face mask, I'm totally for it. In general, patients who are mouth breathers would do better with a mask that covers the mouth. And patients who are able to tolerate breathing through the nose throughout the night would do great with a nasal mask or a nasal pillow. So I leave it more to a discussion with the patient, with the fit, how their anatomy looks like, and whatever they feel more comfortable with.
One really important thing is even the smartest, shiniest, most beautiful, non-invasive ventilator doesn't work if people don't use it.
Right.
And I think, one of the things that we've seen in folks who've come from other clinics is this is not as simple as a medicine where, somebody drops off the machine and you just go to sleep that night and it's great. It doesn't work like that. There's got to be this back and forth that Wissam talked about. There's got to be a respiratory therapist who comes out to the patient's house to instruct them on how to titrate this thing and the different options that are available. And that person should be communicating with the clinic pulmonologist so that the settings can be adjusted. I mean, it takes a little tender loving care to get someone used to this and using it the way that we want them to.
Yeah, that's a really good call out too. So do you think, since it sounds like where you guys are operating out of, you're very proactive and you're bringing these topics up for people and being very thorough from the sounds of it, would it make sense for people to just have some of these things in the back of their mind to share with their respective kind of ALS groups and ensuring that they're kind of crossing all their T's, dotting all their I's on these topics if it's not being prompted?
Yeah, I mean, with Wissam, I'm sure you feel the same way that I do, that really, every person with ALS should have a respiratory therapist and a pulmonologist as part of the team that are taking care of them. And ideally, that respiratory therapist would be someone that can come out to the patient's home. So someone affiliated with the company that supplies the non-invasive ventilator and other equipment.
That's absolutely true. I even see it in patients because in the end of the day, not all companies are the same. Some companies are more proactive than others, and patients probably would also feel that. Whenever you have a good company that's sending appropriate support for these patients will do better, in addition to the support that they may have at home. So instructing the caregiver about how the device works, how to use it is key. And having a company that's ready to pay the patient enough home visits and having the discussion every time they come back to the ALS clinic with their machine, with their mask. I've seen these are the main points to success. And I also take pride in how much our patients are compliant with their devices because we go through all these steps.
So great. Well, okay. And shifting gears a bit. So, because I really appreciate all of that. That's so helpful for people. And then one of the things I think is having certainly Duke stand out is the fact that one of the big topics in what I've garnered in these ALS communities is looking at reversals and understand and starting to kind of just gather as much information as possible. And my understanding is that you put it under this grouping of ALS Untangled. And I was hoping you could share a bit more, Bedlack, about that, and also touching on a bit of what you found in melatonin and if there's anything there for us to understand.
Sure. Yeah. So I can't tell you how much I've learned in my 21 years of running this clinic. So one of the very first things I learned is how many people with ALS are self-experimenting with what I call alternative and off-label therapies. Right now, it's mainly things they find on the internet. There are literally tens of thousands of things on the internet right now that in some way, shape, or form are being advertised as ALS treatments. And, I was never taught this in medical school. I didn't appreciate it in residency. But of course, it makes sense that if you have a disease that's disabling and life-shortening and even at a clinic like mine, where there's tons of things that can be done, we still can't stop or reverse the disease. So of course, patients are going to go home and they're going to explore what else is out there that I might be able to add to what, Bedlack and his team are doing for me. And, people would come into clinic and they'd literally have garbage bags full of all these products. And in the beginning, our nurses were not even documenting those. They would just sit over there in the corner and nobody was talking about them. The patient wouldn't bring it up. The nurses wouldn't bring it up. And so I started bringing it up and I started asking my colleagues, are you noticing this? And how do you handle it? And most of the answers fell into sort of two categories. Yes, of course, we're noticing it, but we tell people it's a bunch of garbage. Don't waste your money on that. If it worked, wouldn't we all be using it? That's what I call a very paternalistic approach. And I think it's not only unhelpful, I think it's disrespectful to patients and families because, number one, they've taken their time to research this stuff and spent their money on this stuff. And if you don't look at it, how do you really know whether it works or not? And then the other was a very autonomous approach, which was, well, you got ALS. I can't fix it, so why not try anything? I mean, come on. We have years of knowledge and training to be able to help people evaluate these products and make more informed decisions about them. What we don't have is a lot of time. So when somebody comes in and they have 30 products, there's no way I can sit down and do the research that's required on every one of those products to tell them whether it makes any sense for them to try or not. But what I can do is build a program that allows folks around the world to submit things, ideas, things they've seen that they're interested in potentially trying, and another team of people that have the knowledge to systematically review these and then publish those reviews on a website so that now, when somebody comes into my clinic and they say, oh, I'm thinking about using coconut oil for my ALS, I could say, well, the ALS Untangled team has already spent quite a bit of time and effort reviewing the possibility of coconut oil as an ALS treatment. Let me print out this review that's written for a non-scientist and show you what this team thinks. And maybe you can make some more informed decisions about the things you'll experiment with. So that's been going on, for many years. We've written, I think, somewhere in the neighborhood of 65 reviews of different treatments that patients have asked about. There's over 500 others that we haven't gotten to yet on our website that, we're trying to get reviewed, but at least we're starting down the process. And so that's one thing. In the midst of one of those ALS Untangled reviews about 10 years ago, someone asked, could you look at this website of this energy healer in New York City?
Yes.
I said, all right, I'll take a look at it. I have no idea how energy healing would work, from a standpoint of physics and biology, but I'll look at it for you. And on that website, there was a video of a person who said they were from Virginia, that they'd been diagnosed with ALS at the University of Virginia, that they'd progressed to where they were completely paralyzed and near death. And there were pictures, of her with widespread atrophy and what appeared to be complete paralysis. And that the University of Virginia told them, there's really not much more we can do. It's time for hospice. And she decided to go seek out this energy healer. And after 2 years of energy healing, she completely recovered back to normal. And so I said, this can't be right. There's got to be something wrong with this story. So sure enough, I was able to find her. She was kind enough to send me her medical records, and she was right. She met today's diagnostic criteria for ALS. She saw a neurologist I personally know there, who's a great neurologist. She did progress to where she was paralyzed and near death and was told it's time for hospice. And now she appears to have recovered. And all this happened 30 years ago, and she's still healthy. She runs a farm in Virginia. So I'd never heard of anything like this before, a complete reversal of ALS. And I put the word out. Anybody else ever seen anything like this? And cases started coming in. Found a total of 55 people like this around the world whose records I have. These are all people that I've overread what their doctor said. And I agree that they did meet criteria for ALS, that they did progress to where they were disabled, and then they did recover. And I've got all kinds of collaborations going on around the world to study these folks genetically, in terms of their RNA, their proteins, their microbiomes, their radiology, their histology, everything I can think of. And I'm also studying some of the same things they tried in small pilot trials to see if any of these things actually do reverse ALS. As crazy as they might sound, I don't have the answer. So why not try some of these things that are associated with ALS reversals? And those trials, Molly, they look very different than the typical pharma-sponsored trials. A typical pharma-sponsored trial is looking for an approvable signal. They need to get their drugs approved so they can start selling them, so they can stay in business. If they don't get drugs approved that they can sell for a profit, they go out of business. Doesn't matter how nice they are. It's about a business. So they're looking for a small slowing in ALS progression that can get a drug approved. And if you're looking for such a small signal in a very noisy disease, you've got to be really careful about who you let in. You got to try to homogenize your population. So they're typically looking for people very early in their disease who have a lot of function. And you also have to have people who are changing fast enough so that you could see a reduction in the amount of change over 6 months. That's a small percentage of the people in my clinic that qualify for the typical pharma-sponsored study. Also, if you're going to look for a small signal, you need to have a lot of in-person visits, a lot of careful testing. That's tough on people with ALS. And finally, you often have to compare what's happening in these patients to what's happening to people who take a placebo. Again, because if you're looking for a small signal, you got to be sure it's real, not just a placebo effect. But in these trials that are based on ALS reversals, I can throw out some of those rules. I mean, this is such a huge signal. I don't need to homogenize my population. I could take almost anybody into these studies. I don't need a lot of in-person visits with very careful testing. I can teach people to look for the things that are so big that qualify as an ALS reversal. And I don't even need a placebo in these studies. If I get a group of people who can walk that were previously wheelchair bound, or who can breathe without a ventilator when they were previously completely dependent, I don't think anyone in their right mind would say that's a placebo effect. So I haven't found that yet, but the design is very popular amongst my patients. The 90% of people in my clinic who don't qualify for the typical pharma-sponsored trial qualify for these types of trials.
Wow. Well, it's certainly a game changer having your kind of caliber of kind of intrigue and look at these different groups and giving this possibility of understanding and untangling what could be there and what we could actually take new steps on versus just, kind of go home, get your affairs in order type of old protocol. So thank you for doing that. And of course, one of the things that had stuck out on the ALS Untangled was a look at melatonin. And so one, just wanted to hear any of your thoughts on that. And two, are there any other sleep-related elements that I might have missed on ALS Untangled, or is that the primary one?
Yeah. So again, we reviewed melatonin because a person with ALS suggested it, put it on our virtual bulletin board. It got enough votes, so it was prioritized by our team. And, as we started to write that, I said, I know melatonin. I mean, people use it to regulate their sleep-wake cycle, like if they're going to a different time zone, or they use it to treat insomnia. Well, my mind was blown when I did this review, because it has a lot more effects, that hormone. It's actually a very potent antioxidant. It can suppress inflammation, specifically types of neuroinflammation that may be relevant in ALS. And it's fascinating to think about the fact that the biggest risk factor for ALS in most patients is age. We rarely see ALS in kids or teens. It's a disease, of older people, and so are most neurodegenerative diseases. And what happens to melatonin levels as we age?
Yeah,
they go down. And so isn't it interesting to think about the fact that maybe one of the reasons that neurodegenerative diseases are popping up as we get older is we no longer have this naturally occurring antioxidant, anti-inflammatory substance, circulating through our brains. And so any other risk factors that we have are much more likely to produce disease now. So I thought that was a really cool potential link between, again, ALS and sleep disorders that I was unaware of. And so as I was reading that, my wheels started turning about, could I ever do a trial of melatonin? And it turns out there have been some studies. One study that was done in people with ALS where they gave whopping doses, of melatonin, like 40 to 60 milligrams a day. Not only was it well tolerated, but there were some changes in biomarkers of oxidative stress in those patients. Wasn't any change in any clinical outcome measures, but again, these were small, short duration studies. And so it just got me thinking, could I do a trial? Could I do one of these replication of ALS reversals trials, because some of the reversals were on melatonin? Could I do a trial like that? And the problem with melatonin, as you probably know, it's got a really short half-life, minutes. So there are long-acting forms, but even those only last a few hours. So you'd have to, you give really frequent doses. You can give it rectally to prolong the half-life because that reduces the first-pass metabolism. But, that's going to create a lot of burden on the caregivers of these patients to, frequent rectal infusions of melatonin. So I'm just been scratching my head thinking about it. And then you asked me about something called circadian rhythm entrainment practices, which I had never heard of before. And it turns out that light is the way that you might be able to naturally stimulate more melatonin production. And we actually did a review of light therapy with ALS Untangled, and that never really came up in that review. But this idea of doing a trial where we use light therapy to entrain circadian rhythms and boost endogenous production of melatonin, that is fascinating to me and may well be one of the next things I do a Roar trial on.
Oh, that is amazing. Oh, yeah. Circadian rhythm entrainment is, again, I'm quite the biased speaker on this topic, but can just be so transformative for so many areas of health. And so I would love to hear more follow-up if you do go down that path. Fascinating stuff there. There's some incredible studies that we could certainly discuss in the future if that's at all valuable, that are just really, really mind-blowing of people's ability to uptick natural productions of melatonin through the source of this kind of dynamic light versus static light throughout the course of the day and night. So really, really cool. So with that, I know we've only kind of scratched the surface on this topic of sleep and ALS. And I know we've jumped in a lot of different directions. Do you think there's anything that we've missed that people should be aware of around this topic of sleep and ALS, or any kind of things that they should on their own be on the lookout for, or anything we didn't cover?
Well, I'll let you go first, Wissam, and then I'll give you my thoughts.
Sure. So my initial thought is, as a cause-effect relationship, I think we're too early to make a determination whether or not sleep deprivation may lead to ALS. Now, there is a theoretical risk that sleep deprivation may worsen ALS. And to your point, Molly, when you were talking about deep sleep and cleansing of neurotoxins, and so that theory is out there. However, proving it is going to be very, very difficult,
Sure.
Especially that we don't have a great tool to measure sleep outside the lab. And I think that's what has been the hump that we have not been able to really cross in terms of making real associations between sleep and other disorders. My hypothesis is that the poor sleep quality may be a symptom of the disease or an early symptom of some disease. I'm not talking about ALS only. For example, dream enactment may be an early symptom of Parkinson. That doesn't mean that dream enactment led to Parkinson, but it's an early symptom of it that you can see 5 or 10 years earlier. So they might be the same process leading to both the sleep problems and the other problem. And in terms of ALS impacting sleep, I think that's a major burden on patients and their families, and putting their families in the mix, because I know that the psychological burden that those families have and the awakenings they go through the night to make sure that the patient is turned appropriately or to respond to their needs are also a lot to deal with. So both the patients and their families should focus or have sleep in their mind and speak out about it if they're having awakening. And I've noticed that in our ALS patients, yes, I go in, we focus about the pulmonary part, the breathing, the cough, the daytime things, but they never mention to me how difficult it is for them to sleep unless I ask them. And to Dr. Bedlack's point initially, we do have certain relatively limited time slots for these patients. We cannot keep them for 12 hours for an evaluation. So they want to go home at some point. We need to be more proactive in the ALS community about this, about asking about it. And I also encourage patients to bring those up. Like if you're not sleeping during the night, let your provider know. If you're taking naps throughout the night because you're not having any good night's sleep, let your provider know. We do have treatment options for this, and no one has to suffer from so much sleep deprivation. In addition to the idea that sleep deprivation may actually make your ALS worse. So there's a lot of reasons for us to address this, and hopefully as a community we'll be more and more proactive in terms of looking at sleep problems for ALS patients.
Oh, that's great. Actually, I did have a quick follow-up question to that. Do you think that there's any value now that wearables are really upticking in the amount of people wearing different types of wearables and some of them recording respiratory rate as one of the markers? Do you think that there's any value there if they start seeing kind of upticks in the levels of respiratory rate during their sleep, or is it, their consumer grade, kind of hard to tell? What are your thoughts there?
I'm definitely open to new ideas in the world of sleep, and wearables is one of them. I don't think we're yet at prime time for wearables to be used as pure medical devices. I use them. Yeah. I look at the data. If a patient shows me that data, I look at them, I see, because they do work on technology that we used to use in actigraphs.
Yeah.
So they do have a valid point to them. In terms of the respiratory rate, I think it's very tricky, because even oxygen levels, like patients where we monitor their oxygen levels throughout the night, which is probably more accurate than the respiratory rate.
Sure, yeah.
Sometimes the oxygen was completely normal, even though those patients were having an uprise in their CO2 level. So will it make me suspicious if they have a significant change in the respiratory rate during sleep? Maybe, but I'm not yet ready to depend on it as a marker.
Okay. No, I appreciate that. Yeah. And good point about the kind of blood oxygen levels too, because certainly there's a lot of wearables that are starting to add those, Whoop, Aura, BioStrap, to name a couple, that are starting to have those markers available. So, but they're not at that diagnostic level. But I like that you're open to having those conversations with people to see if there's any clues in there. Got it.
Just to put it into perspective, up to 30% of patients who may have hypoventilation would have a normal oxygen level throughout the night.
It's a really good point.
I just don't want to be missing. Like, I don't want to give false reassurances with the oxygen that nothing is wrong. We don't need to intervene. There's still a percentage of patients who will need an intervention.
That's a really good call. I didn't realize that. Thank you for that. And Bedlack, are there any other call-outs that you have that we might have not touched on? I know this is a big topic, but anything kind of burning that you feel like we should mention?
Yeah, no, I mean, I think this is another one of those moments in my career, like the ALS Untangled moment when I decided to look into that, the ALS reversals moment. And you asking me to do this podcast, I thought we'd mainly be talking about sleep-related breathing disorders. And it turns out that's important, obviously, but just scratching the surface. And gosh, this is such a common problem and it has so many impacts. And, the other thing is there's so many treatments that we can offer if we just understand that it's there and what's causing it. So we talked about non-invasive ventilation, but I mean, anxiety, depression, excessive secretions, cramps, pain, urinary urgency. These are all things that patients have that can affect their sleep that we have treatments for. So it just occurs to me, and again, I'm so happy to have Wissam because, I mean, I've tapped into him mainly for his interest in pulmonary issues, but he's got a broader interest in sleep that I think I need to tap into more. We need to, Wissam, come up with some sort of questionnaire that doesn't take a lot of time, that screens people for just any kind of problem with sleep. And if it's there, then we need to put our heads together as a team and try to understand why is it there and what sorts of treatment options can we offer. Certainly, we talked about non-invasive ventilation, but all these other things we have treatments for. And I don't think that we've ever sort of put this whole thing together before in a structured way.
Well, this is yet another reason why I'm so grateful for this level of enthusiasm and intrigue and just being willing to explore certain topics and areas and the openness, because I think it's a huge element for people in this arena, whether they're the patients with ALS or the caretakers, because you want to feel like there's something you can do to take action here, and just your willingness to do that is paramount. So thank you. And I will say that every person that we have on the podcast, we always ask them just a couple quick questions about your own personal sleep routine. And so wanted just to hear real quick from the two of you, 3 questions. So the first one is, what is your nightly sleep routine looking like right now?
So I'm actually a very good sleeper, luckily.
Fantastic.
I have no issues. For me, it's about timing. I know I'm a night owl. I've been so for so many years, and I kind of put my schedule around that. Like, I know that if I go to bed at 10, there's no way I'm going to sleep. But if I go to bed at 12 or 1 in the morning, I would sleep right away. So when my baby is not screaming and yelling, I'm actually a very good sleeper.
Yes, totally understand that. And what about you?
Yeah. So Molly, I've learned something that I probably should have learned when I was a kid, but it's just, especially as I get older, my body needs more sleep.
Yeah.
So, when I was younger, I mean, I probably only averaged 4 hours of sleep a night, especially during residency and early years of building this clinic. I mean, I just didn't feel like I needed it. But as I've gotten older, I realized that's not cutting it. And for me I need to be on when I come to ALS clinic. I need to be, focused, present for my patients, optimistic, excited. I need a good 8 hours of sleep. And there's sometimes on the weekends, if I've had a busy week, I might need to take a nap. And so, like, for the first time in my life, I'm actually paying attention to those signals that my body gives me. I'm not just pushing through, and I'm saying, hey, I'm going to be much more efficient overall if I get the amount of sleep I need and don't just push through.
Oh, that's amazing. Well, thank you for doing that. I'm sure your patients and the ripple effect for all of us of the work you're doing, really appreciate it. So keep that up. And then the second question would be, what is on your nightstand? Now, this could be your literal nightstand or like proverbial if you're traveling, or gadgets, supplements, ambiance, apps, etc.
Nothing much, honestly. I have my phone that's charging, but it's turned upside down, and I have nothing else on my nightstand.
Beautiful simplicity. I like it.
Well, for me, it's comic books. So
nice.
There are times, when I've got a lot on my mind. I mean, like I said, this week I've been super excited about this sleep thing and reading everything I get my hands on. But that kind of reading does not help me to fall asleep. That kind of reading gets me churning and making me want to read more. So I need something that's kind of mindless. And my wife and I, we love comic books. We go to Comic-Cons, we dress up. So I've always got a stack of comic books. And I just find that that's a really sort of low key thing to just take me down from the excitement of the science into a good night's sleep.
Oh, I love that. And the kind of the fun, the play. And I think a lot of ALS patients can certainly relate to the importance of just having some of those, relaxing practices in the evening. So appreciate that. And then the last question would be, what has been your biggest kind of sleep aha moment or biggest change to your personal sleep game?
Molly, I'm not pandering to you. It's really been your invitation. This is just it's not something that I remember getting much education about. I've been focused on so many other aspects of ALS care and ALS research that this is definitely one I had only barely scratched the surface of. And I think I understand this problem a lot better now than I ever did because of the questions that you asked me to look into. And I think that our clinic is going to be better and the lives of our patients are going to be better as a result of this podcast.
Oh, that is really, really heartwarming. And I so appreciate that. And again, as quite the spokesperson for sleep, I don't know if you know my backstory, but I basically went through my own period of insomnia, changed my whole life, and getting kind of out of that and really understanding ways to really lean into circadian rhythm optimization and prioritizing sleep in my own life has just made such a difference that it was the source point of creating sleep as a skill. And now we work with, tons of different clients and high performers or in hotels, and all of these things kind of have had this ripple effect. And from that place, it really means a lot to hear the underscoring on the importance of sleep, particularly in an area like ALS. So thank you for that. That's amazing.
So when you go through training in med school, you go to the hospital, you work for 2 years, then you do residency, 3 years, fellowship, 3 years. But so I spent maybe 6-7 years in the hospital, and I had zero regard to my patient's sleep at night. Yeah. I would go in at 5 a.m. because I need to make a blood draw. I would check the blood pressure at 2 a.m. because these were the vital things. And then during my sleep fellowship, I actually worked with someone who's very into sleep in the hospital. And I started realizing how poor of a sleep opportunity we give our patients, and started reading more and more about what kind of impacts this sleep deprivation or restriction or poor quality is going to cause these patients. And this was probably my big aha moment. We spend maybe a third of our life sleeping, and sometimes we decide to cut this short for more important things, where in fact, probably we shouldn't be. So whether it is how I deal with patients who are hospitalized now is different, how I think about the patients in the outpatient setting is different, and how I do it myself and with family members around me has been different. Because now I understand how important this is. for the body as a whole. So that was my biggest sleep aha moment.
Oh, that is amazing. Well, thank you so much, both of you, for sharing all of your incredible information. Again, I know that there's so much more, and I hope we did a good job at kind of touching on the big topics. And then if you do decide to kind of go further, we'd love to have you back, and any other discoveries or thoughts that might come down the pike. We'd love to hear any insights. But to that note, wanted to hear, how can people continue to follow the work that you're doing, or just, kind of the hope that you're bringing?
So the Duke ALS Clinic website, which will be found at www.dukealsclinic.com or .net or .org, it's undergoing a massive renovation now. And it's going to be a lot better here in the next couple of months. We'll have a section on the main page where we talk about the latest things that we're working on. We'll have sections that explain and link to ALS Untangled and ALS reversals. So that's going to turn out to be the best way to follow us.
Fantastic. Awesome. Well, thank you both for taking the time. I really appreciate it, and just really excited to continue to follow your incredible work. And, just the difference that you're making for people is profound. And it has that ripple effect, not just for ALS patients themselves. And of course, that's a huge element of it, but also for caretakers and for, this topic of ALS at large. So just thank you. Thank you.
Thank you for having us, Molly.
You've been listening to the Sleep is a Skill podcast, the #1 podcast for people who want to take their sleep skills to the next level. Every Monday, I send out something that I call Molly's Monday Obsessions, containing everything that I'm obsessing over in the world of sleep. Head on over to sleepisaskill.com to sign up.